Hi, my name's Tom Myers, and I've been in private practice in structural bodywork for over 20 years now, and I've been teaching for anatomy for the past 12 years. And this tape on the myofascial meridians is the product of my researches and my attempt to make a holistic anatomy of the myofascia accessible to my students. The information on this tape gives you a powerful assessment tool to assess global postural problems and also to figure out how myofascial pain can travel along these meridians of myofascia so that where you end up working can be quite distant from the site of pain itself. It will also increase your 3D understanding of the anatomy of the human body. The information contained on this tape is unique in that, for the first time I think, it really gives you a view of myofascial anatomy that's based on wholes instead of parts. So let's go to the classroom and see how it works.
In Tape 1 of this program, Fascial Tensegrity, we laid the tracks for the anatomy train system by learning about the role and development of the fascial net in human beings. Using models like Bucky-Fuller's tensegrity structures, we saw how the myofascial system transmits the forces of gravity, action, strain, and even trauma around the body. To make the learning fun, we compared these myofascial continuities to train lines, and we used this metaphor to present the route map that these meridians of structure follow. In this tape, we'll present each of the anatomy trains in specific detail. By understanding these body-wide lines of transmission, you'll be able to address stubborn local pain problems by unwinding global postural patterns. Further treatment options and myofascial sessions are offered in the Anatomy Trains book, and on our Anatomy Trains Technique series of videotapes, and via our classes. Before we start, let's briefly review the Anatomy Trains rules.
Tracks of myofascial pull through the body, just like train tracks, need to go pretty much in the same direction. You can't make radical changes of direction and still have a line of pull that goes through the body. So rule number one is, of an anatomy train, you can't make radical changes of direction. You have to keep going in the same direction. Secondly, you can't have one set of tracks crossing right over another set of tracks or the trains would collide. So you can't, in the same way as if you have a line of pull going through the body, if it meets another fascial plane going opposite to it, you can't have a line of pull through that plane. So that's the second rule. You can't have one plane of fascia crossing through the other plane and still have the line of pull. The fascial planes or fascial lines of pull are able to divide, kind of like a Y or kind of like this switch here, so that one fascial plane can divide into two and create two separate lines of pull, and conversely two separate lines of fascia can come together and blend into one fascial plane. The tracks are like the myofascia. They run continuously through the body. But the muscles go from station to station, from origin to insertion. And we've been thinking of muscles as just going from the origin to the insertion, and as if that was the only line of pull. But once you start thinking about the myofascial meridians, the myofascial continuities, those are just stations along this continuous track that runs right through the body. We have expresses and locals. Just like the subway in Boston, the express train covers several stations before it stops, and the locals just go from station to station. The express that covers many joints is on the outside. The locals, which cover the individual joint, are deeper on the inside.
All right, with these rules in mind, let's go. We'll start with the superficial front line.
Okay, let's begin. The superficial back line starts actually under the foot on the bottom side of the 5 toes and stretches across the bottom of the foot in the plantar fascia. Now let's see what that looks like anatomically on the slide. You can see the plantar fascia there stretching across the bottom of the foot as one long line. And if we go to the next slide, you can see that the plantar fascia is really providing a bowstring across the arches of the foot, so that as the plantar fascia stays tight enough, it acts like a bowstring that keeps that arch up. And the the plantar fascia ties into the front of the heel bone here. Now, this is a place that where it ties in, the plantar fascia, we say it ties into the front of the heel bone, but it in fact ties into front of the periosteum of the heel bone. So that if you have somebody who is running or doing some other activity where they land like this, bam, bam, bam on the ground, they tug, 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 tug on that plantar fascia, and it starts to pull the periosteum away from the bone here. And bone making cells, which are plentiful between the periosteum and the bone, go, let's fill in the periosteum. That's their program, is fill in under the periosteum. So as the periosteum gets pulled away from the bone, they fill in under there and create a bone spur. However, in our anatomy trains idea, what we're looking at is it doesn't end there. It goes around the heel with the periosteum, or even through the heel with the fascia that goes through the heel bone, and comes up the other side, and we can keep right on going. Where do we go? We go right up the Achilles tendon, and you can see that on the next slide. The Achilles tendon comes up through here from the back of the leg, starting, we'll make it start a little bit narrow here so it looks like a real Achilles tendon, and it comes up from there, getting wider as it goes, to, with the soleus on this side of the Achilles band and the gastrocnemius on this side. Since we're doing the superficial back line, we'll go with that superficial muscle, the gastrocnemius, and that's going to carry us across the knee to where the gastrocs reach up over and tie on to the backside of the condyles of the femur. Now, if you look at this, this whole structure here is also kind of like a bowstring. And the arrow in the bowstring, notched into this bowstring going around here, is the heel bone. So as this gets tighter, as you have a tighter and tighter Achilles tendon, as you have a tighter and tighter muscles, soleus or gastroc, that are pulling on it, you're actually going to push that heel bone right into the ankle joint, into the subtalar joint and ankle joint. And that creates a lack of mobility in the heel. It can create a lack of a good ability to ground through the heel. You see this a lot in people who are leaning forward, because as they lean forward, they tense on the Achilles, and that jams the heel into the ankle joint. Okay, now as we go up here, the next line, the next piece of our line here is going to be the hamstrings, and the hamstrings are going to go up here to the back side of the ischial tuberosity, and now we can see the line from the back here. And but this line through here requires a little bit of explanation. At the back of the knee, we run into our first fudge factor. I set up the rules for the anatomy trains, and every once in a while we're going to have to break them, but we'll learn something each time we break them. Okay, so let's look at the anatomy. If we look at the anatomy of the back of the knee, we can see that the gastrocnemiae, the heads of it, come in and reach up and grab hold of the femurs. The biceps are reaching down outside of them, the biceps on the outside and the semis on the inside, reaching around the gastrocnemius heads to take a hold of the fibula and the tibia, respectively. But that's not really an anatomy train. It's not continual fascia running across there. They run up next to each other, but they don't really hook. But they do really hook when the knee is extended. So if I take and I drop this on the floor and I go down to pick it up with my knees bent, what you see is I disengage that train. But as I straighten my knees, the condyles of the femur come back against the heads of the gastrocs and the tails, the tendons of the hamstrings, and interlock them just kind of like a fireman's carry into one sheet, one line, one band. So that if I reach over to pick this up with my knees straight, I feel the restriction in my hips as I go against that anatomy train, which we now see is starting from right under the toes, going around the heel, up the back through the Achilles tendon and the gastrocnemius, and up the hamstrings to the ischial tuberosities. So it's not an anatomy train when the knees are bent, but it is an anatomy train when you're standing up or your knees are extended. Okay, let's keep going. So, if you're used to studying muscle anatomy, you might think we're stuck here because we come up to the hamstrings, and where can we go from here? What muscle takes off from here where we can't take a radical change in direction, remember? We got to keep going in the same direction. Well, it isn't a muscle. It's a ligament. The sacrotuberous ligament keeps going right on up from the hamstrings. In fact, you can see it really as a kind of degenerated hamstring because a horse has a hamstring muscle that goes all the way up to the sacrum. But ours has degenerated so we can have this nice strong ligament, but it's still a fascial continuity right up from the hamstrings, right over the sacrotuberous ligament, onto the edge of the sacrum here. Well, once we get up to the sacrum, it's really easy because we're in the lumbosacral fascia here, in the sacral fascia, and we can just travel up on any one of a number of erector spinae muscles here that travel up and over the laminar groove here, this trough, until they reach the occipital ridge. And from the occipital ridge, we don't even stop there. We go right over the top of the skull with the scalp, the gallia aponeurotica, if you want the formal name, and right over here to the brow ridge, and here this train stops. Let me give it a little trim here. So this is where this train stops, is right at the brow ridge, right along here in your brow. The fascia comes over the top of the head and stops here. Of course, there's a fascial continuity down onto the face, but the facial fascia is very soft and malleable, and the hard structural stuff stops at the brow ridge. If you think about a fish, as we looked at earlier, the skull stops above the eye, and that's where our original skull stopped, and that's where this line stops. So now if you look sideways on this skeleton, what you can see is this first myofascial meridian that we have starts all the way from the bottom of the foot, goes around up the back of the leg, continues up the back of the leg to the ischial tuberosity, travels over between the pelvic bone and the sacrum, travels up the back in the laminar groove all the way to the occipital ridge, up over the top of the head, and stops at the brow ridge. This is one plane, and it's a plane that you stretch every time you do a forward bend. Any kind of forward bend. The yoga people use the forward bend, the downward facing dog position, anytime you bend over to pick up your keys. But you can really notice the difference in this. For instance, if you take one of your clients who's stiff and they reach over and they can't really touch their toes without bending their knees, you'd say, oh, well, the hamstrings are short. But if you take a golf ball or a tennis ball and you put it on the floor and you have them rub that tennis ball underneath their feet, or the golf ball underneath their feet, and then you have them lean forward again, what you're going to see is this. Because that plantar fascia, all you've done is stretch the plantar fascia. But you stretch that plantar fascia and you will see that that whole line extends. Another piece in thinking about the line as a whole, if I bend over like this, I'm not stretching that whole line, you see? I'm stretching up to my hips and maybe even along my back. But this part in my neck, I've got really contracted. So to lean over and stretch like this is not the same as leaning over and stretching like this, or even like this. So let's look at the superficial back line now as a strip of myofascia that goes over the spinal curves. You can start up here with the cranial curve. The cranial curve is a primary curve. The cervical curve is a secondary curve. The thoracic curve is a primary curve. The lumbar curve is a secondary curve. The sacrococcygeal curve is a primary curve. Now, I know we're stretching a little bit, but the knee curve is a secondary curve, right? And the heel is a primary curve. And the arches are a secondary curve. All the secondary curves that we're looking at here, the cervical when you pick up your head, the lumbar when you start to crawl, the knee when you start to walk, and the arches when you start to walk, are all curves that have to be pulled into being by the balance of the myofasciae. The primary curves are there just as part of the skeleton. The secondary curves have to be held by a balance of the muscles. So now if you look at the knees here, when you're walking, when you're standing, if you jam the knees back into hyperextension, you've got a secondary curve problem. If your arches are fallen, you've got a secondary curve problem. The balance of the knees has the knees off lock, pretty straight, but still in a curve that goes this way. So now it's just an expanded vision of what you've been looking at and been learning, just to see secondary, primary, secondary, primary, secondary, primary, secondary, primary. And the superficial back line is the one that mediates all these primary and secondary curves. So if you see a posture, for instance, here's a common one. If you look at a posture like this, and you compare it to the superficial back line, you can see that the superficial back line is short from my shoulder to my ankle. It's like a bowstring. Here would be a straight posture, well, straight as I can manage in this 50-year-old body, and here would be a short back line posture. One short back line posture. Here would be a posture in which the primary and secondary curves have been reversed. You have a reverse curvature of the knee secondary curve, and that's going to require that you, generally speaking, that you have more of a curvature in the lumbar secondary curve. So these are just a couple of ways in which you can consider the superficial back line as in a clinical way. But the major point that we make here is whatever you see going on in the area of this superficial back line, strain will spread along this line in either direction. I built the line from the feet to the head, but obviously the line pulls from the head to the feet, or from both ends towards the middle, or any way along the line. So you could have an extra short line along the superficial back line in here, or in the hamstrings, and it's going to spread along the line. So knowing the line allows you to say, okay, maybe these hamstrings aren't held right here. Maybe they're held further along the line. Maybe these hamstrings or lower leg aren't short here. Maybe the shortness is really in the plantar fascia. So the power of this is really twofold that I want to sort of get out here as we start these lines in. One is that you can use these lines for global postural assessment to see which line is tighter or which line is looser in a global kind of way. And secondly, these are the lines on which strain travels throughout the myofascia. So if you see really tight hamstrings and you've worked on the hamstrings till the cows come home and they're not releasing, maybe it's here, further up the line, that will allow you to release things. Maybe it's all the way up here. I get a lot of juice from working on the scalp. Maybe it's down in the plantar fascia that's going to help you. So that's the second way you can use these lines, is if you're having trouble somewhere along the line, maybe, just like in those tensegrity structures that we were looking at a while back, the problem is coming from someplace more distant along these myofascial meridians. So the superficial back line, starting from the bottom of the foot, goes around the heel, up the back of the leg on the gastrocnemius and hamstrings, the sacrotuberous ligament, and up all the erector spinae muscles and fascia to the back of the head, over the top of the head on the scalp fascia to attach to the brow ridge, and on its way covers all these primary and secondary curves on the back of the body. Hi, we've come out to the beach on a fairly windy day so that we can show you how these lines get stretched. So if we look at the superficial back line, a stretch for the superficial back line here, you can see how a forward bend, especially if the head is let go, is a stretch for the superficial back line. And of course this can occur in many forms. You can do this if you're just seated and leaning forward, it would be the same stretch. So you can see that this is essentially the same stretch to stretch the same superficial back line. So the superficial front line, as you might expect, is pretty much a balance to the superficial back line. So instead of starting on the back side of the toes, we're going to start on the front side of the toes with the extensor hallucis and extensor digitorum longus, and we pick up the tibialis anterior here from the inside, and we go right over to the knee, like that. But hey, does that look like it? Especially if you look at it from the side? No, not quite. Because if we had muscles that went like that, they'd have great leverage on our toes, but they would, we'd have to have skin that went all the way out around here. So God took this extra little piece of fascia and strapped it around here like that, so that all the muscles of the superficial front line go under this pulley on their way to the toes or the inside edge of the foot there. Now the retinaculum, which you can see here as a separate structure, and you usually see it in your anatomy books as a separate structure, is not really a separate structure. It's just a thickening of that superficial fascia, the superficial body leotard that runs all the way around the body that we were talking about when we were looking at the how fascia is in the body. So here we are on the superficial front line, going in under this retinaculum and up the front of the leg. This is all the muscles of what's known as the anterior compartment. Tibialis anterior, extensor digitorum longus, and extensor hallucis longus, which are known as Tom, Dick, and Harry. So, having come up here to the top of that compartment, we are at the tibial tuberosity. If we keep going in a straight line, you can see this in the anatomy slide, that we get right onto the quadriceps femoris, and as we go up on the quadriceps, the most superficial of that quadriceps is the rectus femoris, and it includes the kneecap. So I've just taken this thing right around and stuck it to the whole kneecap, because the patella is a piece of a pulley. It actually exists within the quadriceps tendon, and we're on the superficial front line, so we'll take right up to the superficial, most superficial muscle here, the quadriceps, the rectus femoris, goes up here to the anterior inferior iliac spine. So we've made it up to the anterior inferior iliac spine here, and we're kind of stuck. There's no muscle that takes off from here, except perhaps the iliacus, and that would carry us very deep. We want to stay on the superficial front line, and so here comes the fudge factor for the superficial front line. I'm going to jump over here. I'll just stick this here for a second. I'm coming over to the pubic bone. This isn't really part of the line. There's nothing here. I'm not talking about the inguinal ligament or anything like that. But I am jumping from here to here, which isn't normally allowed in the anatomy trains. But let me show you what I mean on my own body here. The rectus femoris comes up the leg and to the anterior inferior iliac spine here. The rectus abdominis, which is going to be our next muscle, takes off from the pubic bone and goes up to the rib cage here. Now, if you look, these 2 points are on one bone, the iliac bone here, so the hip bone. So if I tighten the rectus femoris, I'm going to pull down on the rectus abdominis. For every millimeter that this shortens, this has to lengthen. And conversely, if I tighten the rectus abdominis, I am going to pull the rectus femoris into greater length. Okay? And likewise, if I stretch through the whole hip, I'm going to have to stretch both this and this as I stretch the superficial front line, as I would in, say, yoga pose like the cobra, or where I was reaching overhead on a shelf or something, or a bridge, any kind of a pose like that. So this works as an anatomy train as long as I stay right in the sagittal plane. If we're talking about twists, where you turn the body away from this superficial front line, doesn't connect through this area here. But if you're talking about a connection through the sagittal plane, through the plane of right through the front of the body, then the next piece, the rectus abdominis muscle, which comes up here to the fifth rib, and coming from the pubic bone, you can see the linear connection between these two. And as we come up onto the fifth rib, we get on to the sternalis fascia that runs under here. You can see this in the Vesalius slide from way back when, and also in the modern slides here. And the sternalis fascia carries you right up the sternal bone to the top of the sternal manubrium. Who takes off from here? The obvious muscles when you got up here to the sternum to keep going right up the front of the body would be these sternohyoid muscles. But look at the anatomy slide and you will see that these muscles actually go behind the sternum. And what muscles keep going on the superficial front plane? It's your sternocleidomastoid. So the superficial front line, if you follow the anatomy, actually goes up here onto the mastoid process, and then that connects also right up into the scalp. We'll give this one a little trim also. I suppose keeps right on going over the top, but for our purposes it will stop there. And now you can see the balancing answer to the superficial back line is the superficial front line, which balances it all the way up to, let's stick that down, to the the top of the rib cage here, and then look what happens. Look what happens. The superficial front line goes to the back, and in fact goes behind the atlanto-occipital joint where the head is joined to the neck. The result of this is if I tighten the sternocleidomastoid on this side, on both sides, I'm going to do this to the neck. If I tighten the superficial back line, I do this. If I tighten the superficial front line, I do this. So is it any wonder that this is one of the most common postural faults that you can see? Because the superficial front line and the superficial back line both pull the neck into hyperextension, which is something that we always are working on to try to get this to happen. And we're going to see that the only line that really counterbalances this and takes your neck into flexion is the deep front line. So at the, as we look at this superficial front line and we come to understand it, there's a piece about how people react to fearful situations that becomes really clear. If you, and you can see that here in the slide, if you stand behind somebody and surprise them, in this case somebody fired a blank gun behind this gentleman, before he was standing like this and after he was standing like this. So he was shortening the front of his torso and he was shortening the back of his neck. Now, when you see the superficial front line as a whole, you can see what this is. It's a shortening of the superficial front line. The reaction to stress is to return toward the fetal position, is to shorten the superficial front line and protect your body. But shortening the superficial front line shortens the front of the body up to here and then shortens the back of the neck, because that's the way the line runs. To recap then, from the top of the toes, underneath the retinaculum at the ankle, up the anterior compartment of the leg, through the kneecap, up the front of the thigh to the pelvis, jumping across to the rectus abdominis, up the chest on the sternalis fascia, onto the sternocleidomastoid, all together running up the front of the body in the superficial front line. As you can see, a stretch like this would stretch the superficial front line. A stretch like the cobra or the upward-facing dog. And here's a simple stretch for the superficial front line on one side. Okay, so now we have the superficial front line and the superficial back line. Now we're going to look at the lateral line, the line that goes up the side of the body. The lateral line in our evolutionary history, if you look at the lateral line of a fish, a shark for instance, can feel along its lateral line. There was a very, very sensitive motion sensors right along the lateral line of some fish. And They can sense vibration. Now we, as human beings, have concentrated all that vibratory sensitivity into one organ along our lateral line. But even though we don't have vibration sensors down our side, the lateral line does have a myofascial reality in the body, and here we go. So if we look at where the lateral line comes on a human being, it really originates in two places: at the base of the first metatarsal, on the inside of the middle of the foot, and the base of the fifth metatarsal at the outside of the middle of the foot. So starting from the inside, if we put on the peroneus longus muscle to its attachment there on the first metatarsal base, and we bring that up here, and then I'm going to use two for this one for a reason you'll see in a minute. The peroneus brevis attaches to the outside of the fifth metatarsal base. So you see we're really starting from two places. Both of those muscles go behind the lateral malleolus of your ankle, where they're also held in by a retinaculum. And although the brevis stops here halfway up, what we're really talking about fascially is that the myofascia and the fascial compartment is the whole lateral compartment of the leg. So we're going to carry both of them up here to the fibular head, where that myofascial compartment has a connection forward through something called the anterior ligament of the head of the fibula, which you can see here in this slide. So that carries us still up the lateral line, still pretty much in a straight line, and there, with that anterior ligament of the head of the fibula, we connect into everybody's old friend, the iliotibial band. The iliotibial band goes up just put these here to keep them here. The iliotibial band goes up the side of the leg, widening as it goes, and cups. Just kind of stick it together here because it's one long sheet. It's widening just like the Achilles tendon and getting up here to cup the greater trochanter and help to hold that into the socket. The fascia opens up and spreads into a Y here, and many muscles are attaching to it. The tensor fascia lata here, the northern fibers, all right, the superior fibers of the gluteus maximus attach here from the ilium down. And of course the gluteus medius would be here in the middle. I don't have enough gauze to get across here, but you can see this kind of Y deltoid of the hip arrangement here. And so here we are now out at the anterior superior spine and the posterior superior spine of the iliac bone. Now, if we were to keep going in the same direction, we'd have to keep going out that way, see? So here comes our next fudge factor. The fudge factor on the lateral line is that it's not so much of a line as a basket weave. And what we're going to see here is the next set of muscles goes across in another direction. Here is the fibers of the internal oblique muscles. You can see on the anatomy slide there, and coming from the anterior superior spine, the fibers of the external oblique, obviously external to the internal oblique, coming over it, and they form an X here along the side of the body. So if you look at this X here, I'll show you on my body here, it's going right through your waist. And if you reach and grab around to what's left of your waist, you can feel out here on the side the external oblique going this way, and if you grab a little deeper and grab onto it, you'll feel underneath that external oblique the internal oblique, and they're forming an X. So if you look at this line from where we started down at the foot up to here, we started with muscles that came from the foot around the outside of the leg, up here to the fibular head, across to the iliotibial band, widening out to the anterior spine and the posterior superior spine, and now winding back this way. Now, yes, I know it doesn't follow the anatomy train's rules, but it does form a kind of basket weave, and it keeps going with this basket weave. if we look here, what kind of muscle would be going this way? Well, it's the internal intercostals are arranged between the ribs at an angle like this, same as the internal oblique. And the external intercostals are coming over the top of that, coming back in this direction. I'm going to hook it around the scapula here because I'm kind of stuck with the shoulder. But you can see that you still have this oblique arrangement here with the external and internal intercostals. Here's the external intercostals, here's the internal intercostals, just the same as we had the external obliques and the internal obliques. So we're continuing this kind of cross-hatched basket weave, inside-outside formula as we go up the torso. So we continue this interweaving kind of tensegrity arrangement around the ribs, going both directions. So it's a multitude of X's going up through here until we get to the top of the ribs underneath the shoulder. We're not really including the shoulder here. And we look at how does this X express itself in the neck. We have one very, very deep leg of the X way underneath there, in which this part of the leg of the X is the anterior scalene, and this part of the leg of the X is the internal, the superior oblique muscle, the suboccipital muscles. But this is very deep, and this is going to become part of our deep front line. So I'm going to continue. There is an X on top of this. The first part of this X is the splenius capitis, which really comes from over here on the spinous processes and comes right up onto the mastoid process just behind the sternocleidomastoid. And so that's going to take us to the top of that one. I'll just trim that. And the other one on the outside, which is once again our friend, the sternocleidomastoid, coming up onto the skull here, same as it did before. So what you can see if you look at the lateral line is a kind of basket weave or tensegrity back and forth of the elastic lines this way, 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 this way. It's a woven thing that comes all the way down until you get to this strong band, and then it goes down to the leg as we said before. But if you look at the movement here of what happens on your lateral movement, because every time you walk you're doing lateral movement, every time you swum as a fish you were doing lateral movement, and this weave that goes across here limits that lateral movement as you swing back and forth this way. Okay, so that's how the lateral line is almost more a container for movement than a creator of movement. So from the inside and the outside edge of the foot, the lateral line goes behind the ankle, up the leg on the peroneals, up the outside of the thigh on the iliotibial band, crossing the waist with the abdominals, the ribs with the intercostals, and the neck with the splenius and the sternocleidomastoid, all together forming a basket weave on the outside edge of the body. And here's a simple stretch for the lateral line. If you measure the distance from the armpit to the belt on both sides, this is a good measure of the lateral line. If the line from the armpit to the belt is shorter on one side than the other, then the lateral line is generally shorter on that side. Okay, if you looked, however, sideways here, you could also see that these lines are parts of spirals. And so now let's go to my favorite line, the line that travels all the way around the body and doesn't break the rules anywhere, the spiral line. Okay, now let's go on to the spiral line. It was a piece of this line that was first introduced to me by an article by Raymond Dart, the anthropologist, and that's what got me started on this whole thing. And I just take it a little farther than he does, maybe a little more daring, I don't know, maybe a little more foolhardy. We start with the spiral line out here on the side of the occiput with the same muscle that we have over here, the splenius capitis. The splenius is a bandage that wraps itself around the superficial back line, which is the erector spinae. We haven't gotten to the trapezius and the shoulder. That's even more superficial, but right now we're at this layer. The spiral line comes down here to the spinous processes of the upper thoracic vertebrae. I'm not being absolutely specific about which here. What I want you to get is the general idea rather than all the specific numbers. So if we kept going along here in the same direction, what muscle goes over here? The rhomboids go over here and carry us over to the medial border of the scapula, which you can see in the anatomy picture here, going pretty much in the same direction. And I'm going to tuck it under here, but you understand that the rhomboids are going all the way along this whole border, and the next muscle takes off all the way from this border, so that if we are able to look under the scapula here, we would see the serratus anterior muscle, which you can see pictured in the anatomy slide there, going around from the medial border of the scapula, going around and taking on to the ribs. But now, as we keep going in the same direction, okay, let's just take his hand out of his mouth here so he doesn't look so shy. And right here along the ribs, we've got, the, as you can see in the anatomy slide, here comes the serratus anterior, here comes the external oblique, so we can go right along with the external oblique over to the midline of the linea alba, and right across through the linea alba onto the external oblique on the opposite side. You can see that in the slide also. And that carries us over to the anterior superior spine. This anterior superior spine is really one of the places in the body that's, if we were carrying this train analogy on, is really like a roundhouse. Look at what we've got going off from here. We've got the external oblique going up to the ribs, the internal oblique going across here, the internal oblique lower fibers go down to the pubic bone, sartorius takes off this way, tensor fasciae lata goes off that way. You really have a lot of muscles, a lot of different directions of pull coming right off from here. But right now, we're coming down along here with the internal oblique, and we don't have to stop here. We can keep right on going in the same direction. And we'll get his other hand out of the way. And stay there. And Gustav, you hold that. And we keep on going on what? The tensor fasciae lata that's coming here, which gets us onto our old friend, the iliotibial band, carried right down. Maybe there's an attachment on there to that greater trochanter, but definitely down here to the, ooh, who put that on the femur? Right down here, I did. Right down here on the tibial condyle, of course it's the iliotibial band, comes down here to the tibia, and if I'm down on the tibia, where do I go? Right onto the tibialis anterior, and I'd better go underneath this retinaculum here. And that carries right down on the bottom of the foot to the first metatarsal, first cuneiform joint. But hey, we've already seen this. We had another muscle that came to exactly this point, the peroneus longus muscle. It also comes into the joint right here. So they're connected through the joint capsule, and together they form a stirrup that goes right around the foot and comes up, same as the other one did, behind the lateral malleolus. Oops, better put it underneath the retinaculum. And from here, if we go right up on this spiral line, we get to the fibular head. With the fibular head, if we keep going in the same direction, we're going to be right on the biceps femoris, which carries us, whoops, up to the ischial tuberosity on the lateral hamstring, same as we are before, and we can just keep right on going on the superficial back line all the way up the body, up under here to where these erector spinae. And so what you have is a line that connects this side of the head, the left shoulder, the right hip, the right arch, right up back here to the same side of the head. Now if you look at this aspect of the line here, the rhomboids and the serratus together hold this medial border of the scapula. So you could say that the medial border of the scapula is suspended in the rhomboserratus muscle. So if the rhomboids are tight, it's going to pull the scapula up and in. If the serratus is tight, it's extra tight, it's going to pull the scapula down and out. So if you can watch scapular position and see not only that you need to work with these two muscles, but that you're working with something along the whole spiral line. So if you look at this incredible connection along here, I want to make two clinical points about this. If you watch me now, I am going to shorten what I call the right spiral line because it starts from the right side of the head and ends on the right side of the head, but remember it's involving the left shoulder. So if I tighten the upper portion of the line that goes from my head down to this hip, right, down, around, behind me, and over here, watch. Okay? That's shortening the right spiral line. The left shoulder falls off the body, the right side of the head comes down so that the head is moved off to the left of the midline, and the whole spiral shortens. I could do it on the other side. If I let go of that, I could shorten the left spiral line. Now I'm doing a classic shortening of the whole line. It might not exactly look like that, but you can see the implications of this line in spinal rotations. I'm not saying that this line causes spinal rotations, but that it will be involved in spinal rotations. You will see the line shortening to either compensate for or create these kinds of things. Okay, so to look at another clinical aspect of the spiral line, if we start from the anterior spine here or here, and we go down the body, you notice that what we get to is the inside arch, right in there, the weakest point of the foot arch. If we go down from the back of the line, we go down the hamstring, from the hamstring onto the peroneals, and that takes us also down to the weakest point of the arch. If the tibialis anterior and the front part of this line tighten up, they're going to pull the arch up. If they fall, they're going to allow the arch to fall also. If the back side of this line, the hamstring peroneal side of this line, tightens up, it's going to create the arch falling. If it has good span, it's going to allow the arch to stay up. So what we can see is not only do we have a sling around the arch that works through the lower leg, we have that sling continues right on up through the upper leg to the pelvis itself. So in pelvic angle, the tendency is for a fallen arch to go along with the anterior tilt and a high arch to go along with the posterior tilt. So as you can see from the number of ribbons that we're getting on the skeleton now, these lines interact. To keep this tape within bounds, we are putting out the lines as they exist, but it is hard to get into all the interactions of the lines. But you can see how there are some myofascial units that are redundant, that go through several lines, and that's just the way it is. If one line is pulling, it's going to create compensatory pulls in another line. For instance, if you see the spiral line pulling around like this, it's going to affect the lateral line over here. This lateral line is going to shorten. This lateral line is going to be lengthened. So you do have to watch the interactions between these various lines.
So the spiral line sweeps down from the skull to the opposite shoulder, around the ribcage and around the belly to the same hip, and down on the iliotibial band and the tibialis anterior to the underside of the foot, holding the arch in a sling, up the outside of the leg with the peroneals onto the hamstrings, and up the body on the same track as the superficial back line.
Okay, now we have finished the cardinal lines, the north, south, east, and west line, and we have done the encompassing line of the spiral line. We've been looking at the lines that go through the trunk, and we've been carrying them down into the legs because the legs in a human being offer support. The lines also carry out into the arms, and because our shoulders are more specialized for mobility rather than stability, the arm lines crisscross a lot, so they are not as exact as the ones going through the legs. So we're going to go through 4 lines here fairly quickly. There's a superficial front line, a deep front line, a superficial back line, and a deep back line, and we'll be going through them fairly rapidly to keep the tape within bounds here. So watch carefully. At no time do my hands leave my wrists. So starting with the deep back line of the arm, we start again with the rhomboids. The rhomboids carry us right over, the same way as they did on the spiral line, over to the medial border of the scapula, but this time we keep on going out the scapula, and we take up with the infraspinatus and teres minor, and we could be going also from the levator scapulae and the supraspinatus. You can take this line in one of several ways and come out onto the greater tubercle of the humerus, where we join in with the head of the tricep going down the arm. Now this looks like a rapid change in direction, which would be breaking the anatomy train's rules, but if you look at the arm in any kind of extension, you can see how this line is one long line. And that's going to carry us down to the olecranon of the elbow, right here, which is part of the ulna bone. So we go down right along the periosteum of the ulna here, off the styloid process, and on to the outside edge of the arm. And we'll trim this guy off, and there you can see the deep back line of the arm. So the deep back arm line starts from the spinous processes, go down on the rhomboid, and then out on the rotator cuff, down on the triceps to the elbow, and down on the ulna side of the arm to the little finger. So the superficial back line of the arm, which we'll do over here on the other side, starts from the trapezius, which is of course the most superficial muscle in this part of the body. So we could start from here, from here, from here, from here, from here, but let's just start it from the head for convenience. And we would have the trapezius going over to here on the acromion process and the clavicle, and who takes off right from there. You could almost call it the trapezio-deltoid muscle, because that goes over the top here and down onto the deltoid tubercle. And as you can see in the anatomy shot, from the deltoid tubercle, although it's interrupted by the head of the triceps, we come down the intermuscular septum here, the lateral intermuscular septum, to the lateral epicondyle, which you can feel right there, just above the elbow. And that takes us on to the extensor muscles of the back of the hand, which carry down underneath the retinaculum here, same as the ones do at the ankle. I suppose we cut that off at the end of the fingers. And what you could see here is the superficial back line of the arm. So the superficial back arm line starts with the trapezius, continues with the deltoid and the lateral intermuscular septum, down to the lateral epicondyle, and down the backside of the forearm to the backsides of the fingers. The simple stretch works for the back of the arm lines. If your client leans back with the arms laterally rotated, you get a nice stretch on the superficial back line of the arm. If the client leans back with the arms medially rotated, you can feel it going right through the rotator cuff and the rhomboids in the back of the scapula there. Now let's turn our attention to the front lines of the arm. First, the deep front line of the arm. The deep front line, starting from the front of the body, would include the pectoralis minor muscle, not the major, which would come up here to the coracoid process, that little piece of the shoulder, the scapula that sticks through to the front. And here we turn and go down on the coracobrachialis towards the arm, and again, it looks as though it breaks the anatomy train's rules, but if you look at the arm when it's stretched out, or if you were hanging from a branch, you can see that this complex of myofasciae are what hold the arm to the chest, which is a good idea when you're swinging from branch to branch and suddenly, boom, landing on that branch with the whole weight of your body. So next time you're swinging from branch to branch, you can be grateful to your pectoralis minor, which helps hold your shoulder onto, helps hold the rest of your body onto your shoulder in that instance. Now, coming out here, we pick up the brachialis and the supinator the way we showed you when we were looking at expresses and locals, and that carries us down onto the radius. We could also do that with the biceps if we were taking the express. Coming down here onto the radius and out the periosteum of the radius, over the styloid process, and onto the thumb side. So if you look, you can see very clearly that the thumb side of your body is connected up through the radius, through the inner part of the arm, to the inside of the chest on the pectoralis minor muscle. For those of you who are watching who are shiatsu people, who use your thumbs, when you press down on your thumb and really put weight on your body, it's got to come up and through and meet your chest here. If you are pressing on your thumb and you're taking it into your back, you're asking for trouble, and so are your clients if they do something like that. If you follow the anatomy train's lines, you'll see where the tension has to go to make it integrate into the body. This line starts on the ribs with the pectoralis minor, slides down the biceps part of the arm, and gets onto the radius side and ends up on the thumb of the hand. Okay, so now let's go look at the superficial front line of the arm. The superficial front line of the arm starts with several familiar muscles. You have the pectoralis major in the front coming this way, but you also, strangely enough, again I say the arms are really diverse because they're so mobile, you also have the latissimus coming in from the back. Now, latissimus dorsi means the widest muscle of the back, but I'm sorry, it feeds into the superficial front line of the arm. Latissimus, teres major, and pectoralis all together, but I'll represent it with this line from the pectoralis major, come into the humerus here in the intertubercular groove, where you can get from there with them onto the medial intermuscular septum, this division here between the flexors of the arm and the extensors of the arm, and carry down onto the medial epicondyle of the elbow, which you can feel right here on the inside. And as you go down from that, you get right onto the flexors of the arm, that whole common flexor tendon, which takes you down through the carpal tunnel and into the palm of the hand, like that. So this, if we look at how you stretch these two lines of the arm, the front lines of the arm, the superficial front line goes from the palm, up the front of the arm, up the inside, and on to the pectoralis major. The deep front line of the arm comes from the thumb, up the radius, up the biceps and the muscles underneath it, and into the pectoralis minor. So the superficial front arm line starts with the pectoralis and the other muscles, comes down the inside of the arm to the medial epicondyle,
gets onto the flexor group, and ends up on the palm side of the hand.
As I say, the arm lines, if you look through here and you hold me to all the detail, you'll find that there are exceptions to the lines. Things cross more than they do in the legs, and that's because the arms are really designed for mobility. Here's a simple stretch for the superficial front line of the arm. You let the client lean forward, bringing their breastbone forward, and you turn the arms so that they're laterally rotated to the edge of comfort of the client. To stretch the deep front line, do the same stretch, but with the arms medially rotated. Now, if you want to think about how these lines work functionally, they really go across the body from the shoulder girdle to the pelvic girdle. And so what I want to do now is extend these arm lines into the functional lines, which show you the connections across the body between the girdles. So we'll have a front functional line and a back functional line. So what we're talking about here is an extension of the arm line, the superficial arm line in this case, that we're coming down from this whole superficial arm line, but I'm just going to start here. Let's just start here with the pectoralis major muscle. That muscle comes down, interdigitates with the upper fibers of the external oblique, comes down just about beside the rectus and down here into, as you can see in the slide, right down onto the pubic bone. But look what happens if we keep going. Keep going in the same direction, and as you can see, we get right onto the adductor longus, and the adductor longus goes behind the leg and ties to the linea aspera on the back side of the femur, right in there. See? So you have a tie-in from the right shoulder to the inner part of the left leg. It makes a lot of sense. Imagine you're a pitcher in a baseball game. You wind up. When you pitch with the right hand, but you use the left leg for support. You pivot around that left leg to get the full force with your right arm. Well, it makes a lot of sense now in terms of this myofascial meridian coming down from the right shoulder, across the pubic bone, and deep into the left leg. You can't go any farther with this because when you get down to the end of the adductor longus, you're in that linea aspera in the back part of the leg, and there are lots of other fasciae crossing over in other directions, so that has to be the end of this line, right where that big, strong adductor longus attaches into the back of the femur. Obviously, there is an equal but opposite line going down the other leg. But if you think about it, one of those lines is bound to be stronger than the other depending on what handed you are. If you're not ambidextrous, if you're using your right arm more than your left, especially in something like tennis or any sport that's handed, you're going to see differences in these lines from one side to the other.
So the front functional line comes from the arm lines of one shoulder down across the chest, across the belly, crossing the midline of the pubic bone, into the adductors of the opposite leg, so that each shoulder is joined to the opposite hip.
Okay, there is a similar corresponding line, functional line, in the back that goes, let's detach these lines here, that goes from the latissimus attachment, we could say, for starters, although we could pick up the teres in there, but if we use the latissimus, we might pick up the little bit of the scapula there with the latissimus. That happens in some people, not in others. And that would take us down to the middle of the thoracico-lumbar fascia. We cross right over that fascia as it crosses over the body and down through the sacral fascia And we pick up what? Well, we've picked up the same muscle, the gluteus maximus, but these are the superior fibers that go into the iliotibial band, but now we're on the inferior or sacral fibers that go underneath the iliotibial band on to the gluteal attachment 1/3 of the way down the shaft of the femur. So you can see we're stabilizing across to here, similarly as to the other side. But you know what? It doesn't stop here. What happens if we keep going around the leg underneath the iliotibial band? What muscle would we get to? That's right, the vastus lateralis comes right down in the same direction. That outermost one of the quadriceps comes down, picks up the kneecap, as we talked about before, and ends right here on the tibial tuberosity. And I suppose we could carry it down into the foot, but this will do for now. What I'd like you to notice here is that once again, the shoulder is stabilized to the opposite leg, in this case to the femur and to the knee. So if you consider that in terms of a backhand, here I go, the line goes up the back of the arm, connects into the latissimus, goes across the latissimus to the opposite leg and around to the knee. That's quite a long line. That's the line that you would use in a backhand shot in tennis. It would also be the line that you would break, I mean B-R-A-K-E, slow down the motion if you were doing the pitch. You'd be using the front line to create the pitch and using that functional line in the front, but the line in the back that we just looked at would be stopping that motion, keeping you from throwing the joints out of place. So that line would come down across the back again and over onto the opposite leg. The same thing, I suppose, would be true for the backhand. Once you got to the limit of the backhand, this front line would be the break. That would stop you from going too far and damaging the joints. But you see these lines going really across the body. That's where you get the functional connections, the things that really make the body integrate and work as a piece of movement. So the back functional line likewise joins the arm lines, but this time across the back of the rib cage, the thoracico-lumbar fascia, the sacral fascia onto the gluteus maximus, the vastus lateralis, right around to the tibial tuberosity, thus joining the shoulder to the hip across the back. So those are the arm lines and the functional lines that hook the arm lines to the opposite parts of the pelvis. You've been very patient, and Gustav's been very patient, but we have one more line that we'd like to show you, and that's the deep front line. Okay, now our last line, the last line we're going to look at is the deep front line. I'm not saying that these are all the lines there are in the body. You may even be able to discover your own once you have the idea of the Anatomy Train's myofascial meridians, but this is the last one that I'm going to put out on this tape anyway. And this line is very important and is more fascial than muscular. So we've been looking at a lot of the myofascial chains, and this has a few muscles that go along it, but you have to follow the fascial planes, the intermuscular septa, to really see this one. So watch closely. Here we go. We're going to start on the bottom of the foot with the attachments of a muscle called the tibialis posterior. We would also include, I really want to stay with this deep muscle, which comes right down here and has a tendon like a hand with about 5 or 6 different fingers that hold on to most of the bones that are under the tarsum of the foot. So it kind of supports that medial arch as it does so. We could also include the flexor hallucis longus and digitorum longus, and they go on up around behind this medial malleolus on your ankle, up in behind here, and deeper than your Achilles tendon going into the back of the leg here. So again, if we looked at tibialis posterior, flexor digitorum longus, and flexor hallucis longus. We got another Tom, Dick, and Harry coming back here into what's known as the deep posterior compartment of the leg, which you can see on the slide here. Now, this deep posterior compartment goes onto the back side of the fibula and the tibia and ties into this interosseous membrane way deep in the leg. So here we are going up the posterior side of the leg, and we get onto the fascia of the capsule of the knee. And this is also, again, we're following more fascia than muscle. You could think about the popliteus in this level of fascia. However, it's just really the capsule of the knee and the fascia that's going along with the neurovascular bundle, the bundle that's carrying the nerves and the blood vessels. And it crosses the knee with the neurovascular bundle, with the bundle of nerves and blood vessels, and cuts through back to the front of the leg, from the back to the front of the leg, through a hole in the adductor magnus muscle known as the adductor hiatus. So you may think it's strange that the deep front line actually starts out on the bottom of the foot, which is where the back line started, and goes to definitely the back of the leg. However, biologically, this was the front of your leg. Your leg, when you were a salamander, when your granddad's granddad was a salamander, your leg faced this way. This was the front of your leg. In the course of embryological and evolutionary development, both, the leg turns in so that what was the front side of your leg has become the inside or the back side of your leg. So here we are back on the front of the leg. Now, the next journey that this deep front line takes is up the intermuscular septum that runs between the quadriceps muscle and the adductor muscles. This is the line that you can see in this Vesalius slide, and it takes us right up the side of the linea aspera, the front side of the linea aspera, on this plane up to the femoral triangle, which is right in, let's just stick this to the side. Femoral triangle is right in here, and call it the groin. You also can call it the leg pit, because it is to the leg what the armpit is to the arm. Here you've got the blood vessels and the nerve, the femoral vein, artery, and nerve going through here, and you have our favorite muscle of all the body, the psoas, going through here. So you can travel up here on the psoas into the groove created by the transverse processes and the bodies of the vertebrae, of the lumbar vertebrae. I'm drawing this as if it's a line, but it's actually a series of muscles, one to the fifth, one to the fourth, one to the third, one to the second, one to the first, one to the 12th thoracic vertebra. So here we have a line going up through the body that starts from the bottom of the foot, goes up the back of the lower leg, around to the inside of the thigh, up to the front of the hip, and across behind the guts. This muscle is retroperitoneal. It's behind all your intestines and attaching to the side of the lumbar vertebrae here. This area of the groin here and the hip is just so important. Again, it's such a common postural fault to see the hip closed or the lower back pulled forward, and by cause of the muscles that go through here. And when I first started working, nobody had heard of the psoas and nobody knew what it was, and now when I go to teach people, everybody thinks must be the psoas. So I want to get a little more clarity in this area here. So here's the psoas express. This is the express muscle going through here. Now, if you looked at just below the psoas attachment, almost in the same place, is a muscle called the pectineus. And the pectineus comes up here to the iliopectineal ridge on the pubic bone. And if you wanted to keep going in this same direction, you could get on the psoas minor, for those people who have a psoas minor, which would carry you back up, carry you back up on top of the psoas to T12L1. So you could cover this same distance with the pectineus and the psoas minor that you covered with the psoas. Let's cut this off because there's another here. There's another local here that runs outside the psoas. You can see that this pectineus, if I could get it to stick, is running inside the psoas. Here comes another one outside the psoas. The iliacus or iliacus comes along here, starts with the same tendon as the psoas, but opens up into the hip here and fills in this whole inside of the iliac fossa, but its top attachment here is along the inside of the iliac crest. If you keep right on going from the inside of the iliac crest, you get right on to the quadratus lumborum muscle, which also takes you up to the 12th rib and the first lumbar vertebrae. So, if you had to get from the inside of the leg to this area of the 12th thoracic vertebrae, first lumbar, you could take three routes. You could take the psoas express up the inside here, you could take the pectineus and then psoas minor local, or you could take the iliacus quadratus lumborum local. All of these need to be considered when you're thinking about fully opening up the hip so that people get full hip extension. I guess it's obvious, but there will be an equal and opposite deep front line. I hope it's equal. Oftentimes it's not equal. In all the cases of scoliosis, pelvic imbalance, these two lines are not going to be exactly equal, but in terms of anatomy, there's an equal and opposite line coming up over here and coming up on the psoas on this side. Now, if you, once you get to here, the bifurcation stops, and as far as the line goes, we're going into a lot of structures that are singular. It's not that there's an equal and opposite left and right side, but there is one structure. For instance, the next one we're going to is the diaphragm. There's only one diaphragm. But this oneness, in terms of the deep front line, carries on down here in terms of the anterior longitudinal ligament, which you can see in this slide goes right down all the way to the tailbone. So if we were to look at this as an anatomy train, we could start right here, and we're just going to consider the anterior longitudinal ligament here. We go down around, I got to get around this metal stuff here, and down onto the tailbone, across the pelvic floor, which you can see in the slide there. See how that pelvic floor, especially the pubococcygeus muscle, is just an extension of the anterior longitudinal ligament coming across the floor of the pelvis. But hey, we don't have to stop there. We can get right on the rectus abdominis and carry ourselves right up the front of the spine. So, right up the front of the body. So you could say, I know that we've already put the rectus abdominis in as part of the superficial front line, but now I would like to give you the idea that the anterior longitudinal ligament and the pelvic floor and the rectus abdominis are kind of a long tail to the spine. At least, maybe a tail is going too far, but they are definitely part of a line here that surrounds the abdominal balloon and gives shape to the abdominal balloon. And sometime when we talk about this a little more, we can put in the clinical implications of this. But I wanted you to see that if we had taken the deep front line down from the top instead of up from the bottom, we'd get down to this place. We could either go straight down the spine and onto the pelvic floor, or we jump onto the psoas, which would take us left or right. So now we're going to continue going on up from here. And if you look at the slide there, you can see that there's a clear interdigitation here between the fibers of the psoas coming up like this and the fibers of the diaphragm coming down like that. If you look at the interface between the crura of the diaphragm and the psoas in your anatomy books, it looks as though they're completely separate. But I'll tell you, if you do any dissection, you will see that the fascia is absolutely continuous from the psoas to the crura of the diaphragm. It is really hard to tell where one stops and the other begins. The diaphragm arises out of these fibers of the psoas and out of the anterior longitudinal ligament and comes across in a dome here, which you probably can't see, but you know where the diaphragm is anyway, don't you? The central tendon of the diaphragm comes across here and attaches to the xiphoid process on the back. So that is one route that we can take with the deep front line. this whole root here, the inside of the chest is part of the whole root of the deep front line, but we're going to take a few different roads through here. So one would be to take the diaphragm forward to the back side of the sternum, and then we can travel up. Can you see my hand inside the sternum here? Travel up the transversus thoracis, come up behind the sternum, and let's see, we'll make our little guys do that here. Come up behind the sternum, and where are we? We're behind the sternum on those little guys that go right on up. Here, we'll take Gustav's head off just for a moment, he doesn't mind. That go right on up to the hyoid bone. In fact, they go inside the hyoid bone and out like this to the floor of the mouth. So the most forward route, if we took the most anterior route up the deep front line, we would be going from the diaphragm over the central tendon of the diaphragm to the xiphoid process here, up the back side of the sternum, the inside of the sternum with the transversus thoracis and all that fascia, and come out the top at the behind the sternum and up these little muscles here to the hyoid bone and forward to the chin. That's one route up here. And obviously we could continue with the jaw muscles which hold the jaw to the face. We won't go through all those in detail, but just to understand that the visceral part of your throat is connected down through your chest into the deep front line on the front side of your spine. Okay? All right, that was the front root for the deep front line. Now we got a middle root of the deep front line. We go up and forward on the diaphragm again, but this time we stop in the middle of the central tendon. What's attached to the middle of the central tendon? Look at the slide, you will see that the pericardium is attached to the middle of the central tendon. The pericardium is the bag around the heart, and that's part of a big connective tissue structure which runs front to back here in the chest, like that, and contains the pericardium and the visceral pleura of the parietal pleura of the lungs and all the tubing that's in here. And if you come right up with that, you come up to the top of the lungs and the top of the heart with all this fascia of the thoracic inlet up here. And inlet or outlet? I always forget. Anyway, coming up here to the top of the dome of the lungs, you get onto the scalenes, and the scalenes carry you right across to the anterior tubercles. These muscles are major, major suspensory muscles. The scalenus anterior, middle, and posterior are major. Of course, they go to the ribs, but the inner fascia actually goes to the lung itself, actually holds up this mediastinal tissue. So you could say that the organs are suspended between the psoas and the quadratus lumborum on the bottom and the scalenes at the top. This fascia is really important in holding up the organs. So our middle root with the deep front line in the chest goes up the diaphragm, through the pericardium of the heart, out with the connective tissue of the mediastinum, and up on the scalenes and the scalene fascia onto the cervical vertebrae. As I mentioned before, there are also little muscles back here that connect those vertebrae to the back of the skull, so that would be the end of the line going in that direction. Okay, and just one more, the back root of the deep front line is just the continuation of the anterior longitudinal ligament right up the spine, and it would go right up to the top of the neck and would attach to the skull. So if we put the skull back down on there, you can see this baby coming right up, I'll just have to show you on here, and attaching to the front of the skull, right in front of the skull. So if we, I don't know if this is going to work, if we put Gustav back on there, you could see Gustav's head back on there, you could see this line coming right up the front of the neck and going right into the bottom of the skull, where you can see it there on the anatomy slide. So that's the third most deep the third posterior part of the deep front line. This is a very complicated line. It's a line that has a lot to do with our psychophysiology, because it's right where the organs attach to the back. The backbone is our biggest part of our doingness, part of our moving around, the part of us that we think of is in control. The gut part is much more ancient and asserts its control when it needs to. And it is attached all the way along the front of the spine here through the mesentery and the mediastinum all the way up. So this deep front line, especially in the trunk here, is right on that interface. And to me, this is another way of speaking of this is as a core line. And if you really want to get balance in the body, and if you really want to get the deepest kind of health and the deepest kind of full expression for the person, getting length along this line all the way from the inner arch, all the way from the inner arch way down here, up the back of the leg, up the inside of the adductors, and up the front of the spine, getting that front of the spine to lengthen, that's what really produces health and full expression in a person.
The deep front line starts deep in the plantar surface of the foot, runs up behind the calf in the deep posterior compartment, swirls around to the front on the intermuscular septum, picks up the psoas, goes to the front of the spine, and follows the anterior longitudinal ligament all the way up to the skull. In the interface between the organic body and the musculoskeletal body, this is the deep front line.
More complex poses like this stretch lines in combination. You can see that the lateral line for most of the body is being stretched by this pose on this side. However, the spiral line is being stretched from this side of the neck around to the opposite hip. And in the forward leg, you have a stretch in the deep front line from the groin down to the foot. Obviously, it would be the same on the other side for the other sides of the lines. Come on up. Well, there's the general exposition of the route map of the anatomy trains, the myofascial meridians running through the body. With the information in this tape, you have a powerful tool for going after the postural patterns and the pain patterns that your clients bring to you every day. Over the years, as a client, as a practitioner, and as a teacher, I've become more and more convinced of the power of simple touch to heal the human heart. Bodywork and movement therapies can not only heal myofascial pain, but also the psychological and developmental restrictions that constrain the human spirit. Remember as you work that you're on the cutting edge of something that will be part of not only of the health care of the coming generations, but even contribute to the physical education of the children coming along. Other tapes and books in this series will be exploring the specific applications to various problems that we see in our practices every day. And so we hope you can join us for those, and we hope that you found this tape useful and entertaining as well.